Hello everyone, and thank you for joining us today. I'm Rene Ruiz. I'm the Area Director of Business Development of Civitas Senior Living here in the Greater Austin area. And it is an honor and privilege to have you join us today. We are at Ledstone Senior Living. It is our campus of care here in Dripping Springs, where we have independent, assisted, and memory care services here on campus. It is absolutely gorgeous and breathtaking. We've got hill country views surrounding us, and wildlife and deer. It's an amazing community. We have a beautiful outdoor pool and walking trails. It's absolutely gorgeous. Our residents here are vibrant, active, and engaged. We are going to be joined here shortly with Ryan Carpenter. He's with Austin Geriatric Services, AGS for short. His medical director is Liam Fry, and Liam Fry is our medical director here at Civitas in the Central Texas area. So she and her nurse practitioners come into our communities almost, at least twice a week in each of our communities and visit our residents, their patients, and let us know how they're doing and let us know if there's any sort of change of condition. And that way we can alert family members and get everybody on the same page in terms of what is going on with their loved one. Without further ado, let's bring in Ryan Carpenter with AGS. And today's topic is going to be on diabetes. It is National Diabetes Awareness Month for the month of November. And so we are very fortunate to have an expert here in-house with us today to help answer some questions that and dispel myths that we might have regarding diabetes.
Hi, how you doing, Renee?
I'm doing great. I've got Ryan Carpenter, nurse practitioner with Austin Geriatric Services here with us today. And Ryan and his team are nurse practitioners. They also serve as our medical director. So Dr. Liam Fry is amazing, and she and her team of nurse practitioners are in our communities very often, many times during the week, and take care of our residents. Ryan, tell us a little bit about yourself and a little bit about AGS.
Well, thanks, Renee. So AGS is a company was started in 1984 here in Austin by Dr. Peggy Russell, who was one of the early pioneers in geriatric medicine in this town.
Awesome.
And she was able to establish a presence in what we call the post-acute spectrum of care, which is kind of from the hospital back down through the skilled network setting into assisted and independent livings. And our current boss, Dr. Liam Fry, who you just mentioned, she assumed control of the company in 2015 when Dr. Russell retired. And since then, we have expanded over the past few years. And
you're everywhere.
We are in over 30 skilled nursing facilities, over 60 assisted and independent living facilities. And over the past couple of years, we have also incorporated a home care program where we take care of patients in the home to complete that continuum of care from the hospital all the way back to the home.
Oh, I love that.
Yeah.
That was a missing piece.
It absolutely was. In addition, we have clinicians in the hospital setting. We do the hospice and palliative care services for multiple Seton hospitals throughout the Central Texas area in order to, again, keep that geriatric influence in the continuum of care.
I love that. Well, thank you so much and welcome. So here at Civitas Senior Living, we own and manage several communities, 7 currently here in the Central Texas region. So you and I guess all of your nurse practitioners, they're in frequently. You take care of our residents. You help them from day one of admission in some cases, sometimes even right before.
Yes.
I think it's been an excellent working collaborative relationship and one that we definitely value, and I know that our families and our residents definitely value, so thank you so much again for your services.
We're very happy to be a part of the Civitas team. Our goals and visions for care of the elder adult align very well, so it's been a great partnership.
I completely agree. Today, Ryan is going to be our expert speaker, and the topic that we've got this month, it's American Diabetes Month here in the month of November. And we're going to ask Ryan a series of questions because he is an expert in this area. And the first is, can you describe what diabetes is, Ryan, and how it impacts seniors who live with that disease on a daily basis?
In the setting we're talking about, I think we're primarily talking about type 2 diabetes, which is colloquially called adult onset. Not always adult onset, but people may know it by that term as well. And that is typically defined as it's a chronic illness, and it's one in which the body, the regulatory system, without getting too deep into it, stops allowing the absorption of blood sugar, or blood glucose as we call it, from the bloodstream into the cells. And that has to do with a hormone called insulin. Insulin is produced by an organ called the pancreas, and over time as we age, there are two main factors that can upset that regulatory system. One being what we call insulin resistance. You may have heard that term. It's become kind of a hot buzzword in the past few years, and that simply means the cells which use the glucose for energy are resistant to allowing the insulin to enter the cells. And the insulin has to be able to enter to get the glucose in to provide the energy. So that's called insulin resistance. The other factor that's at play here is the pancreatic function decline. The pancreas itself is what produces insulin. And so when the production decreases, the impact on the blood glucose or blood sugar circulating in the blood decreases. So that leaves you with a situation where you have all this excess blood glucose in the blood and it's not being absorbed into the right place, which is the cells. And it's a pretty common problem. You mentioned it, being an expert in it. We kind of have to be when you work in the geriatric population. Over 50% of the over 65 population are pre-diabetic. That's 1 in 2. Half of us.
That's significant.
And of that, 30 to 35% are true diabetics. So a third of all the patients we see have type 2 diabetes. Yeah, it is a very, very prevalent illness in this population.
Tell me, how does diabetes impact seniors living with the disease?
That's an excellent question. It is an all-encompassing illness, unfortunately. And by that, I mean, it does affect every aspect of your life. It is a disease of chronic illness. So unregulated diabetes, i.e. not monitoring and managing the levels of sugar floating in your bloodstream, really lead to a host of illnesses based on vascular changes in your blood vessels, especially the small blood vessels in your body. And of those in particular, your eyesight. You get what are known as retinopathies. The retina is like a wallpaper on the back of your eye. It has a bunch of little vessels that absorbs light and helps you process images. So unmanaged diabetes can lead to vision problems and even blindness. It's actually the third leading cause of blindness.
I didn't know that.
The third in America. It also leads to microvascular changes in the heart, leading to heart disease and heart failures.
It's almost a precursor to all
absolutely, as well as kidney dysfunction and kidney disease, and the brain. The brain is a very vascular organ, yes, and it can push and accelerate dementias. And cognitive declines. So it is. It affects every aspect of your life.
So the sooner, then, I guess, it is detected. And you get control of it, or some sort of control over it, you're in a much better position than those who go unchecked.
Absolutely. Early intervention and management is key. You can really prevent a lot of these things from happening through not only medication management, but diet and lifestyle changes, like you mentioned, not smoking, watching your weight, getting your weight down, staying active. A sedentary lifestyle is the absolute worst thing you can do. Not only for diabetes, but for heart disease and hypertension and everything else.
Well, those go hand in hand. That's very interesting. I had no idea, actually, that was leading to all of that. So does an older person's lifestyle impact the severity of the disease? So like you said, if they are a smoker or they're overeating or eating the wrong types of foods, I mean, tell us about that.
Absolutely. It all starts with diet and exercise. What we do from the medical management side should always be considered a secondary process. If you're not managing your weight, managing your activity levels, making proper dietary choices, and you are a smoker, all of these host of things lead to a worsening of the severity and your incidence of becoming a diabetic.
Wow. I mean, is it possible, Ryan, that you could go without doing medication, be it metformin or insulin? Insulin is the last resort, I'm assuming. Is that correct?
Yes.
Could you get it under control and then go back to being not diabetic?
Yes and no.
Okay.
That's a great question. And we have quite a few residents within the Civitas community too, who we have been able to educate and assist with a game plan of weight loss and increased activity. We've actually been able to take them from an early diabetic state where they are on metformin and some oral medications and even insulin in a couple of cases, and they've lost enough weight to where we kind of pulled them out of diabetes back to a pre-diabetic state.
Okay.
And they've been able to come off these medications.
What do they do? I mean, just continue with the diet, exercise?
Exactly. Be mindful of the diet. Try to lose the weight. Stay active.
Yeah.
Smoking and drinking, those kind of things all just add to the problem. And not always, I need to say that too, I need to preface it with that not always are we able to manage it completely out of diabetes. Some people have gone to, have progressed to the point where they're going to have to be managed with medication or insulin, as you said earlier, for the rest of their lives. But even in those patients, the weight loss, the increased activity, it'll help with the blood pressures, and it will help with the severity of the disease and the progression, how quick the disease progresses for the person.
And so the medications, so we were mentioning metformin, and then we mentioned insulin. Can you kind of go into a little bit more as to how these help the body regulate insulin production?
Without going into such a deep dive on it, the oral medications we have typically work by one of two ways. They're typically sensitizing the cells to accept the insulin, as we talked about earlier, that is being presented to them, and the glucose to allow it into the cell. Those are insulin sensitizers. And the other class sort of stimulates the pancreas, kind of whips the pancreas to produce more insulin.
Yes.
So they work in two, and those are the two methods that I was telling you about that lead to the failure of the body to actually accurately regulate insulin in the first place. So sensitizers make the cells more sensitive to accepting the glucose from the insulin, as well as the pancreas making more insulin. Once we're beyond the use of those last for a certain amount of time, and then we get to a point typically, if the disease continues to progress, which we do have to switch to insulin, to injectable insulin. And that is an exogenous form of insulin that we inject into the person, depending on whatever schedule they're on, to supply insulin into the body, because the pancreas has typically quit producing it totally, or produces it in such little amounts that it's not detectable in the body and it's not allowing the glucose to be absorbed.
Wow. And then there's different types, right? So there's, to administer the insulin, there's true injections, right?
Yes.
A typical syringe.
Yes.
And then there's a pen, like you dial up the pen with the dosage.
Yes.
And then there's something called sliding scale. Can you kind of elaborate and educate us on what those mean?
So luckily we have a lot of options in how to approach the treatment of diabetes these days. We have weekly shots that are not insulin, but they do help with that sensitivity. And we have daily one-time shots called basal insulins, which provide sort of a background insulin coverage. Then we have the pre-meal insulins, the rapids, rapid insulins. They work fast. You take it before you eat a big meal to keep that spike from happening.
Okay.
And there are such things as sliding scale too, which means that you'll take a blood sugar and then you dose according to what that blood sugar reading is. We don't use those in these settings because it doesn't address the problem. It's chasing the problem.
I see.
So what we would rather do is address it early, manage the blood sugar so we're not seeing these big spikes and we're not chasing the rabbit, so to speak, all day. You'll get better control that way, and you'll slow the progression of the disease that way typically.
Great. Again, if you don't mind, just to kind of reiterate the lifestyle tips that seniors can use and implement daily to control diabetes naturally.
Yes, so Exercise. Stay active. And exercise doesn't mean get out, do jumping jacks, calisthenics. It just means getting active, moving your body, going for a walk. I know in Texas sometimes it's 100 degrees outside, but there are times like right now where the weather's really nice.
This is ideal.
Yeah, this is ideal. And Civitas has provided exercise rooms and areas for activities to occur. So
absolutely.
There's no real excuse not to get up and move. And obviously, smoking and drinking are two big ones that just need to go, especially from a diabetic management standpoint. Avoiding white foods.
Really?
Sugars. Sugars, obviously, we're talking about sugar with blood sugars, but carbohydrates are sugars too. Potatoes, starches, breads, rice. Those are quickly converted into...
all the good things.
I know, right?
Jeez.
So, the answer is eat the rainbow. You want to eat colorful foods.
Yeah.
Absolutely. Everyone's heard of the Mediterranean diet. This is omega-3 fatty acids, lean proteins.
So salmon.
Lots of vegetables
and
fruits. Absolutely.
So not keto, but just a more well-rounded diet.
Well-rounded diet with
carb intake.
Yeah.
Okay.
You don't have to be true keto. That's not really a sustainable lifestyle for most people. It's about limiting the sugars, and people a lot of times are very surprised where these sugars are. Mm-hmm. Sugars are in everything.
Yeah, tell us about that.
A baked potato, for instance.
Sure.
It's a root vegetable. It's a tuber. You think, wow, that's a healthy meal. Your body looks at that as a bowl of ice cream because that's how it's processed. All of that becomes sugar. These white starchy foods. Mm-hmm. So rice.
Love rice.
Rice, right? I mean, who doesn't love rice?
Love sushi.
Pasta, right?
I mean, really, right? All these good things.
I know.
So we can have them, but can we have them in modified form? Yeah.
Moderation. Everything in moderation. They shouldn't be the majority of your diet in any shape or form.
Yeah.
It should be vegetables and proteins with lean proteins. Fats are not terrible. We've come around from the days of fat-free now and realized that really wasn't the target issue. The issue is the sugars.
Okay.
So, limit the fats just from a cardiovascular standpoint, but fats are not terrible.
Okay.
Lean proteins, fats, vegetables, and fruits.
Excellent. Thank you. What about the sugar alternatives? What are your thoughts on those, and how do diabetics incorporate those into their diet?
Those have a place in the diabetic diet. However, there is new research that's showing that a lot of these can actually stimulate the same receptor mechanisms in the body that sugar does, and your body can almost consider them as a sugar. Not all of them, but some of them.
Okay.
My understanding is the more natural ones, the stevias and things like that, are better recognized as an alternative by your body and are better absorbed.
Okay.
So we want to stay away from the aspartames and some of the ones that
they have
have been around for the 70s and 80s.
Yeah.
Yes, been around for years and years and years.
Okay.
So it's better to stay away from sweeteners in general.
Okay.
Although I know we all have a sweet tooth.
I do.
If you talk to someone who has really truly made a lifestyle shift and a change into a lowered, I don't say low or no, but a lowered sugar diet, sugar is a very addicting molecule, and when you're able to remove it or reduce it in your diet, you do start to seek it out less and less over time.
Really?
Your craving for it decreases. So
that's very interesting.
Sounds very hard to do.
Yes.
It is at first, but it's like everything. You get over the hump initially, and it's doable.
Okay, excellent. So in your role, Ryan, as medical director for Civitas, how do you help our residents manage their diabetes or their pre-diabetic status?
As the medical director for Civitas, our goal is to not only provide education, teaching, and give your residents sort of a recipe to follow to improve their lifestyle and their dietary choices, but also as geriatricians and geriatric trained clinicians, we are all able to tailor the medical management of diabetes in your residents specifically to their needs.
Okay.
Diabetic management is not a one-size-fit-all model, especially for the elderly patient. We have different parameters, different goals with our diabetic management for the elderly. And this is one thing that really sets us apart as geriatric trained clinicians, in that our focus is different for a diabetic patient than, say, a primary care physician's would be for a 30-year-old. Further, we are able to help them manage routine screenings for things such as the retinopathies we were talking about earlier, for eye issues, cardiac issues, renal function, and monitor things like their serum hemoglobin A1C, which is something we haven't talked about. Big fancy word. All that is, it's a 90-day average of your blood sugar that we can look at by drawing blood.
Okay.
And that gives us a pretty quick snapshot of how you've been managing.
And you all are able to do that?
Absolutely. We do it all in-house.
Okay.
So you don't have to leave here, and are able,
wonderful.
to keep you in your home and enjoying your life.
Exactly. Eliminate the need to go off to see a doctor off-site.
Yeah, we try to stay in the background and out of your way so you can live your life, but be there if you need us.
Absolutely. I love that very much. And I know our residents appreciate it as well. Any myths, Ryan, that you can think of that are related to diabetes?
Sure. I think one of the big ones we see is only fat people, only overweight people have diabetes. And that is absolutely not true. We have a lot of elderly residents who are quite thin, frail elderly residents who have never been a diabetic as well, and may suddenly slide into diabetes.
Why is that?
And it's some of the reasons we discussed earlier. The pancreas quits working in producing insulin at a large enough rate, or the cells, just over years and years of being assaulted by sugar, quit absorbing that sugar, the insulin resistance we're talking about. So it has nothing to do with what we call body habitus or your size.
Gotcha.
Which is another important reason for the regular screenings and to be on the lookout for things that can be indicative of an undiagnosed diabetes.
Okay.
And some of those are increased thirst, weight loss, lethargy or fatigue, and increased infections, which unfortunately are a lot of the things we see in our elderly patients anyway.
Right.
So it takes a sharp-eyed clinician to really be on top of it and managing the patients to pick up on that a lot of times.
Excellent. Thank you. Any other myths that are out there?
Yeah. One I hear a lot is, well, I'm old anyway. It doesn't matter if I manage my diabetes.
It definitely does matter.
It absolutely matters.
Yes.
And going back to what I had said earlier, which is diabetes is a disease of chronic illness, and this is a cumulative affair. So we have to continually manage this illness.
Absolutely.
And because our residents are full of life, and they're not at the end of life. They have a lot of life left in them, so we want to help them maximize their potential.
Absolutely.
By keeping everything in check for them. So yeah, absolutely. It's not a time to give up. It's a time to continue and get with an expert, get with a clinician who can help you manage it in the proper ways.
And that's why it's so great having you here on site.
Yeah.
You know, you're able to make those visits in, weekly and check in on our residents, your patients. And if you note a change of condition, quickly let the staff know.
Sure.
We'll let the families know. And really just keep everybody on the same page with respect to new developments with their loved ones. So thank you again.
You're welcome. Yeah, and we are in our Civitas facilities at least twice a week every week. We have a minimum of twice a week because we feel you need that repetition to be able to really establish baselines on patients. So we can see, I know all my residents by name, and I can go down the hall and
they do. They look for you, Ryan. You
well, and I can tell if
after.
something's going on, and that's because I'm in the buildings a lot, and I think you have to be.
Yeah.
Not always in front of them, harassing them, but I'm in the background, like I said.
Right. Yeah. But they definitely look to you, as the expert. Absolutely.
Yeah.
So that's excellent. Can you tell me, how do we help a friend or family member that may be pre-diabetic or maybe has a new diagnosis of diabetes? What are things that we can do to help them?
That's a great question. I would say, first and foremost, support. Give them the educational tools that we have available, and you can seek us out for that. You can phone a friend, so to speak, call a clinician, call a friend. There are a lot of resources in Central Texas to help people with diabetes education and management, especially for the newly diagnosed diabetic patient. and talk to the experts, talk to your clinician, talk to your primary care doctor, get the info needed. If you have a brother, loved one, relative who has it and you feel they're struggling, there are support groups for diabetics.
Are there really?
Yeah, absolutely. And there are diabetic education pieces ad nauseum out there now, and not only in person, but there are online diabetic education resources.
So virtual, if you want.
Absolutely,
to.
And we can post some of those later if you
want.
want.
I would love that. That'd be great.
I'll post a link to a lot of those for you. Education's key. I can't say that enough here. Education's key.
Yeah.
Give people the knowledge to manage their illness and the resources to do so.
Yeah, and as me, as a family, if I had a family member, I would want to know everything there is to know about the disease, and if they needed to start having insulin, I think that my anxiety level will start to go up. But I would need to know how to manage that should they ever in a situation where they couldn't manage that.
Sure.
So is it scary, the administration of the insulin? Are there things that is it painful?
I think anytime you're talking about a needle, people have a little bit of anxiety.
I'm going to run away from a needle, but
relatively speaking, however, if you've ever looked at a diabetic insulin needle, they're almost, as my eyesight gets worse, they're really hard to see, but they're very, very tiny, and they just go right under the skin.
Okay.
It's what we call a subcutaneous injection. It goes into the fat layer right under the skin. It doesn't go into the muscle. It's not a big painful injection. And if people really are averse to it, there are transcutaneous monitoring systems now where there is a needle that stays in you. It's one of these small little ones. You don't feel it. It's kind of taped down to you, and it will constantly give you feedback and read your blood sugar levels, and it will administer insulin as needed, so you're not constantly having to poke yourself.
Oh, wow.
Yeah, those are options, and quite a few of our residents do that. Really frees you up. It's a great option. It really frees them up to enjoy their life without being, chained to a testing kit all day.
And is it bulky? Is it a bulky
No,
device?
they're very small. A lot of them now are about the size of a pager. The ones that actually administer the insulin. There's also a monitoring system that does not administer insulin, but it's worn as almost a little sticker. It's about like the size of $50.
I think I've seen that on some of our residents.
And you can take your smartphone and put it up, and it'll tell you your reading instantly.
Really?
So then you can administer insulin without having to do the finger snap.
Okay.
Yeah, it's great. We use that quite a bit.
Last question on that, though, Ryan. If they are doing the true injections,
sure.
Do they bruise? Are there areas where it's swollen?
You usually don't bruise terribly. I mean, anytime you put a needle in the body, no matter how short or how thin, there is a chance of hitting a little vessel, and you could bruise a little bit. It's not going to be a massive bruise. It may be, half the size of a dime or something usually. Very painless. And once you get in the habit of it, people are able to do it pretty easily without issue.
Wow. Excellent. All right, Ryan. So you have diabetes. You get that diagnosis. Now what? What do you do? Where do you go?
Well, you seek out the advice of a clinician who is able to work with you and manage it. It's not the end of the world. It's a chronic illness. It's an illness that you are just going to have to make some robust life changes to deal
your life,
with effectively.
Right?
Yes, it will. There's no way around that, but it doesn't have to alter your life in such a way that it negatively impacts your ability to enjoy your life. I think a lot of people think, oh Lord, I can't eat anything, I can't do anything now that I've got this. My life's over, Trust me, I'm a foodie. I understand. I'm
a foodie too, and I love carbs.
It's more of, as you mentioned earlier, a shift toward moderation and understanding how these foods affect your body and how they affect your blood glucose levels. And working within that realm. And that is, as we said earlier, it's a lot of lifestyle modification as well as some medical management. So talk with your clinician, go over your fears and concerns with them, and come up with a good game plan. Early intervention is key with most illness. If we can catch it and intervene quickly, typically the progression is going to be less severe than it would be if it goes on for a long time. Unfortunately, most older people are not even diagnosed till they have probably had it about 6 years, is what we think is the average. Yeah, so it goes
So is it not included as part of a physical, or is it, what are the tests to determine that?
So really it's A1C monitoring.
Okay.
It's a blood sugar monitoring test. Now, we don't just run every blood panel there is because, insurance would not like that either, but it's needs to have been, we need to be cued in to order that test. So it goes back to what I was talking about earlier, having an astute clinician. Usually you're going to have symptoms of increased thirst, lethargy, a lot of more infections, and by infections I mean not only skin infections or non-healing skin wounds, but urinary tract infections, which are common in our older adults anyway, because of the amount of sugar that's spilling into the urine from the blood. Bacteria love sugar, so wherever there's sugar, there's going to be an aggregate of bacteria. And those kind of things are what we're looking for. Hunger. Even though you have all this sugar in your body, it's not going into the cells to be used for energy. That's what your cells in your body use. Without that, your body feels like it's starving, because you are. In essence, you're starving. So those are the things you got to pick up on. And weight loss. Weight loss is a big piece.
Really? I thought they would be heavy, though.
All that sugar is packed into the blood. And it's not going anywhere but in the bloodstream and causing irritation to all those vessels that we talked about earlier, not being stored in the cells. So you see a progressive weight loss. You'll see some mental status changes, some cognitive changes.
Those are big signs.
They
symptoms.
are.
I mean,
and unfortunately, there are also symptoms that are tied to a lot of other illnesses within the older population.
So is it recommended that maybe once a year at your annual physical, you do that specific test?
If you think you're
predisposed.
And most people, I shouldn't even say most people are predisposed. Most people have a family history of diabetes now in some form or fashion. If you feel like you're having some of these symptoms, talk to your clinician about it, and they'll determine the appropriateness.
Thank you so much again for coming out and participating today with our discussion. You shared a lot of information with us. I also want to thank the team here at Ledgestone Senior Living. Again, it's a beautiful campus of care with independent, assisted, and memory care services on site in beautiful Dripping Springs, so beautiful hill country views surrounding you. So gorgeous campus. I absolutely love it. So thanks again.
Thank you.
We appreciate it very much, and happy holidays are coming up.
Yeah, you too. Make smart dietary choices.
Absolutely. Thank you so much, and we look forward to seeing you again soon.
Thank you.
Does diabetes run in your family? If so, please be sure that your loved ones watch this video with you. For all of those who like, share, make comments on this presentation, you'll be entered to win a free step tracker. In the comment section, please be sure and let us know your tips and tricks for staying healthy and or managing your diabetes. We appreciate it. Thank you so much.